So if you all have questions, we're going to keep time at the end, but I'm going to be covering dummy pelvis, what is the mechanism of normal labor, touch upon different types of abnormal labor, and then we will discuss further. Now, the whole idea of our teaching program is to help you to optimize the obstetric practices, and you all should learn what are the common topics that we need to cover, and you should also know what are the current trends and updates. And for this, knowledge is the basic what you should know about what you are trying to teach. And in fact, dummy and pelvis is something which has not changed over the last 200 years. So in fact, it's a very good part which you need to study for your exam point of view for practicals. And if you're able to answer this, it's almost guaranteed that you will be passing in the practicals. So women's health and maternal and child health is not given as much priority in healthcare as it should. But WHO and our national organization, FOXY, keep having various themes which talk about women's health. But when we come to dummy and pelvis, we are talking about normal labor and birth. You must remember that there are certain things which you have learned in the first year which are very important. One of them is the classification of the types of pelvis. Remember the number 4. There are 4 planes, there are 4 diameters, and there are 4 types of pelvis. Now, in these 4 types of pelvis, the common types are gynecoid, android, anthropoid, and platypelloid, which, if translated in layman's language, would be female type pelvis, male type pelvis. Anthropos means ape-like, and platypelloid is a transversely flattened. And it is more common in certain races. But there are mainly, you need to know a little bit about what is the specific feature of each pelvic type, because this can also be asked as a short note in your theory paper, a particular pelvic type. And based on which race you're studying or which population you're looking at, the proportion may be different. But so the percentages given here in the chart are just average across the globe, but it varies from place to place. But what you must remember as a rule of thumb, the female type pelvis usually has rounded brim. The forepelvis is generous. And in fact, the side walls are not convergent. So this, what I have in my hand is an articulated bony pelvis. So when I'm talking about the inlet, this is the pelvic inlet. The side walls are, these are the side walls. Subpubic angle is this part. Okay. And here you must remember that the subpubic angle of 90 degrees or more is compatible with a normal pelvis. Now, ischial spines are the ones which are, these are the 2 ischial spines which jut inside the mid pelvis. And these are important because they come to the plane of least dimensions. And the greater sciatic notch, where I'm putting my fingers in, are also described in the various pelvic types. More important is what is the effect of labor. You need to mute the others, please. Saurabh, there's a lot of background noise.
Yes, ma'am. I have mute.
So in the normal gynecoid pelvis, it is usually compatible with normal labor. But now, does that mean a gynecoid pelvis can never be contracted? That is not true, because you can have something known as a generally contracted pelvis, where all the dimensions are shortened. The shape of the pelvis may still be gynecoid, or the other factor is the baby may be large. So hence, if a woman asks you, the doctor, will I definitely have a normal delivery? It's hard to say until she's at term, and that's why clinical pelvimetry is done after 37 completed weeks or when she goes into labor, whichever is earlier. The android or the male type pelvis is actually considered to be one of the most dangerous types of pelvis because the shape is sort of okay, but it is where the inlet may allow the head to get engaged. But these are the pelvic types where you may have what is known as a deep transverse arrest, which is at full dilatation, where there is no further progress. And the obstetrician feels that, oh, the head is just there. And sometimes the caput, which is the collection of fluid which makes the scalp bulge down, is mistaken for the actual station, and vacuum or forceps is applied. So these are the types where you land up with failed vacuum, failed forceps. Usually, you have to think that was it an android pelvis? Anthropoid or ape-like pelvis, you must remember, has a long antero-posterior diameter, but the transverse diameters are compromised. And this is compatible with the occiput rotating posteriorly with face to pubis delivery. I'll be coming to details of these deliveries little later in the talk. Lachypelloid is where there's a transversely flattened kind of pelvis. So, antero-posteriorly flattened pelvis. So what happens is that the CPD or the cephalopelvic disproportion or fetopelvic disproportion is manifest pretty early in labor, and this usually lands up with an early cesarean section. So as I was telling you the 4 numbers, so let me again show you the bony pelvis, okay? So this, and when you're holding the pelvis, you have to hold it in a normal anatomical position, which I'm sure your anatomy teachers have told you, where the anterior superior iliac spine and the pubic symphysis, if you would put it against a wall, they would be in a straight line, or it is tilted 60 degrees to the horizontal. In the viva, you should hold it in the anatomical position and describe it as having 4 types, 4 bones, 4 joints, and 4 planes. Now, the 4 planes are the plane of the inlet, plane of greatest dimensions, which is below the inlet, plane of least dimensions, which is also known as the interspinous plane, and the plane of the outlet, which is actually not a plane. If you look at the outlet of the pelvis, it is actually 2 triangles joined by the ischial tuberosity as the base, the line through the ischial tuberosities. So that is the urogenital triangle, and posteriorly is the anal triangle. And the axis of the birth canal, which passes through the junction of the transverse and anteroposterior diameters of each plane, is J-shaped. And this is something you must remember, and it goes downward and forward. Now, this is a summary table. Now, numbers may be different based on which textbook you're following or which, which population is being described in that particular textbook. But an easy way, which I find to remember, is remember the numbers, like I told you, number 4 for the pelvic types, and 11, 12, and 13 for pelvic dimensions. And try to remember which is the smallest dimension in the pelvis first. So when we talk about the inlet of the pelvis, okay, we are talking about the inlet. In a gynecoid pelvis, it would be more of a transverse oval. So the narrowest diameter would be which one? It would be the anteroposterior, which, to confuse you, unfortunately, in the books, they have described it as conjugates. In which conjugate you can have obstetric, which is the true conjugate, which is the actual diameter, which has to be traversed by the fetal part. That is 11. So anteroposterior, transverse diameter, and oblique diameters. Now the oblique diameters are named by the posterior ending. So if I am touching the right sacroiliac joint here, this is the right oblique diameter. And from here, what starts is the left oblique diameter coming across the pelvis. So remember, the 4 diameters of each plane will be anteroposterior, transverse, and the 2 obliques. And the easy way to remember is remembering number 11, 12, and 13, where the smallest diameter for each one you should remember. Inlet is anteroposterior is the smallest, which is 11. A plane of greatest dimensions, drop the least number. So even if you say 12, 12, 12 or 12, 12, 13, it's fine. But what is important is the plane of the ischial spine, so the plane of least dimensions. What is smallest is the one which is going to give most trouble in labor. So when you're talking about plane of the spines, I'm showing you the lateral view. These are the ischial spines. Now, when you say least, again, you drop from the drop the big number, so drop 13, and the smallest has to be the transverse, which is between the 2 ischial spines. So it is, and normally the biparietal diameter of a normal fetal head is 9.5. So for a vaginal birth to occur, you expect the diameter of the head to be at least 1 centimeter less than what is the pelvic dimension. So here 10.5 is the transverse, 11 is the anteroposterior, and the oblique is 12. Now coming to the outlet, as I told you, there are 2 triangles. The Ischial tuberosities, imagine you are sitting on the chair. The bony part of your butt, what is touching the chair are the ischial tuberosities. So when we are examining a patient who's lying on the table in front of us, if I put my fist in between the part which is lying on the table or the examination table, this is known as the fist method of Jarko. And if the four knuckles of your hand can be accommodated between the ischial tuberosity, it means that that outlet, at least the base of the outlet, seems to be adequate. So this is called the fist method of Jarko in clinical pelvimetry. Now this is a diagram which here again, when you're looking at a diagram, you have to be clear, are you looking at it from below upwards or you're looking at it from above? So students, if you look at it, you can see that here there is a little point which is saying a little bulge showing inwards. So this is what they're trying to represent as the sacrum. So this is anterior, this is posterior, and this is left and this is right. So this is showing various possible positions of the fetal head. You'll find that normally when we go through most textbooks, left occiput anterior for convenience is described as the most common position in labor. One logic or reason for this is given that we talked about the oblique diameters being described as the posterior ending of the diameter. So the right oblique diameter would be from here to here. So the broader part of the fetal head would be accommodated without the sigmoid colon coming in the way. So that is thought to be one of the reasons why left occiput anterior is thought to be a common position where the long part of the head is accommodated in that right oblique diameter. But most of the studies do suggest that the transverse diameter is probably more common and they always rotate. So hence, if you're asked to describe mechanism of normal labor, you can go conventionally and describe it left occiput anterior because most of the books have described that, or you can talk about occiput transverse also. Now this is a close-up of the fetal head. Remember that the fetal head is different from the adult head. Look at your own face in the mirror. More than almost 50% of your face is the facial skeleton, whereas in the fetus, it is not so. It's just about 1/4 or 1/5 is the facial part. The rest is the head. And the head or the cranium or the brain box, which is in common man's terms, is comprised of different types of bones which are joined, the flat bones, which are joined by certain special joining areas, which are the sutures and the fontanelles. Now, the sutures and fontanelles are designed by nature to allow brain growth. Now, brain growth, it has been said, is by nature and nurture, which occurs from as early as second trimester and can last up to 1.5 years, which is when the fontanelles and the sutures are all finally fused and done with. Two important things from obstetric point of view you must remember is the Y-shaped, where my cursor is pointing, is the posterior fontanelle, which is known as the lambda, which is like the Greek letter lambda. And this diamond-shaped soft area called the bregma or the anterior fontanelle. Both these can be palpated by an experienced person when the membranes are absent in labor. And in fact, sometimes if the membranes are flat or thin, you can palpate it even through the membranes. This gives you a clue to the position of the head when you're examining, but this obviously is possible only when the cervix is already open. The other thing you must remember is these two are the parietal eminences. Now, parietal eminence, or the prominent part of the parietal bone, between the two, the biparietal diameter is 9.5 centimeters. When you talk about normal labor, you're talking about the head being like a circle, although it's an oval. So the diameters which are passing are the biparietal diameter and the suboccipitobregmatic diameter. I will show you that in the next slide. But what is important to remember is that the position of the head, and these are the various bony points you should be aware of. This is the lateral view of the fetal head showing you various diameters. Pay a little attention to this slide, it is important. What I was talking about was the suboccipitobregmatic diameter. Suboccipito, now I showed you the occiput. Occiput is also a bone when you describe anatomy. But in obstetrics, when you talk about occiput, it is considered to be that bony point in the just below the lambda, which is the marker which is used as a denominator in various positions when you're describing normal labor. So the occiput is anterior or posterior or whatever. So when I talk about the presenting diameter in normal labor, you can see that the suboccipitobregmatic diameter, which is this one, which is marked, which is from the bregma to here, is the presenting diameter. And this part at the back here is the occiput, which is the marker or the denominator. And as I mentioned, that the biparietal diameter is also, so you're talking about the fetal head being round and two diameters you're talking about. But when you are asked what is the presenting diameter in normal labor, you should be talking about suboccipitobregmatic of 9.5. This diagram is also showing you the diameters in various other types of labor. Let's go to number 5. Number 5 is also 9.5, submentobregmatic. The difference is, it is when the neck is fully extended and you are having a face presentation. The diameter is the same. So why is labor more difficult in face? It is more difficult because the face is a soft, rounded, soft part, not like a hard, rounded head. The irregular parts are not able to dilate the cervix that effectively. Often it is associated with a loose hanging bag of membranes. There may be early rupture of membranes, which and face presentation may be associated with other problems in the fetus. Another thing, molding. Now we talked about the suture lines and fontanelles. The phenomenon of molding is nature's beautiful way of allowing a borderline pelvis to deliver a baby who is reasonably sized vaginally. By overlap, the forces of labor can achieve overlap of up to 1 to 1.5 centimeters to reduce the fetal diameter and allow vaginal birth. So molding is not possible in face, whereas it is possible in a cephalic presentation, which is when the vertex is presenting. So these are the reasons why, although the diameter is the same, submentobregmatic 9.5, suboccipitobregmatic 9.5, but the normal labor is much easier and better in the well-flexed head. Suboccipitofrontal is where the head is partially deflexed, and occipitofrontal is classically described in occipitoposterior position with a deflexed vertex, where, as you can understand, the diameter is more, the occiput may remain posteriorly unless it flexes completely or extends completely to become face, and hence normal labor can be a problem. Mentovertical, particularly brow, that is where actually the extension to face is more important, because if it remains a persistent brow, 13 centimeters, or some books describe 13.5 centimeters, cannot possibly deliver vaginally. So if you're asked a question, what is the management of brow in early labor? You will actually say that you will look for factors which go against having a normal delivery. If everything else is fine, you can just observe and see, because the brow may flex completely and become vertex, or extend and become face, in which case normal labor or vaginal birth is possible. But if not, then the answer is cesarean section. So we talked about the bones of the fetal head. The facial skeleton is cartilaginous, fused and firm at birth, whereas the vault of the skull is membranous ossification, flat, more pliable, leaving small gaps, which are the fontanelles or sutures, which I talked about. Now, one or two key points before I go to the other aspects of today's talk is there are 2 or 3 phenomena which are often asked to you in Viva. What is quickening? What is lightening? What is engagement? Be very clear with your definitions when you're discussing in practicals. Quickening is the first perception of fetal movement by the mother. And this is important to also help us in dating. And obviously, it's going to be earlier in a multipara than a primary. Lightening is when the woman feels the pressure on her abdomen has gone down. This is usually when the head starts getting going lower in the pelvis and the lower segment is getting formed. But proper engagement is when the broadest diameter of the fetal presentation has crossed the inlet of the pelvis. So this I showed you what was the inlet of the pelvis. When the broadest diameter has gone inside, that is when engagement has been said to occur. Longitudinal lie with cephalic presentation is the most common, 96% at term. However, remember, in preterm birth or preterm labor, abnormal lies, abnormal presentation can be up to 25% at 28 weeks, which is 7 months. And when you say the presentation and presenting part, again, we are talking about definitions. Presentation is a generic term. Cephalic presentation means head down. Can be, again, they say life attitude is most important. So the act will determine whether that cephalic flexed attitude, where the whole fetus is rounded up and presents itself like a compact oval, that is cephalic presentation, with well-flexed head is a vertex, is the presenting part. When it is completely extended, and when I say completely extended, it means the occiput is touching the back. That is an attitude of complete extension. That is seen in face, where the presenting part, we often use the word loosely, face presentation, but actually it is face is the presenting part, but the presentation is cephalic. Now, brow is the third, which I talked to you about. Brow is where it is in between the two. And as I said, if it's 13 centimeters, it either has to flex or extend for a vaginal birth. This is showing you a pictorial representation of what I just said, that longitudinal lie, that is the long axis of the fetus and the long axis of the baby are in the same plane. I want you to just see this part. Obstructed labor of 8% as a cause of maternal deaths is global statistics. I'm happy to say that in our country, our city, we have almost eliminated this because we know that the sun should never set twice on a laboring woman. And this is one of the patients in which I had done the cesarean section. This is a patient who had come to us with a uterine anomaly which had led to a problem. And if it was not detected, it could have led to sequelae. So hence, we as obstetricians should be aware that normal labor is hard work, as they say. That's why it's called labor. But a laboring woman, if things go wrong, it's called dystocia or abnormal labor. Eutocia is the other word used for normal labor. So abnormal presentations can be malpositions and malpresentations. Now, when I say malposition, we are talking about only one particular thing, which is occiput posterior. Now, here you can see in this picture, I told you that left occiput anterior or transverse is considered to be one of the most common presentations. This is showing you right occiput posterior. Again, it is falling in the right oblique diameter. In fact, as I told you, right oblique diameter is not obstructed by the sigmoid colon, which is a soft tissue obstruction. So although right and left oblique diameters are the same, malposition or malpresentation, which comes in the right oblique diameter, are more common. So the right occiput posterior is 5 times more common than the left occiput posterior because of the presence of the sigmoid on one side. And here, this is showing you a malposition of occiput posterior. This is showing you a podal presentation, which is breech. And here, this is showing you shoulder presentation. Now, I'm going to talk first about occiput posterior. If you remember, when I started the talk and talked about types of pelvis, I used the word deep transverse arrest. This can also be asked as a short note. And remember, when the word deep transverse arrest is used, it means it's self-explanatory. Deep meaning the head has gone deep down in the pelvis. Transverse meaning the denominator is in the transverse position, the occiput is in the transverse position, and arrest means there has been no progress of labor, biological limit for that particular patient. For example, different, of course, societies use different guidelines, but the cutoff which is usually taken is the second stage of labor should not last more than 1 hour in a multiparous patient, 2 hours in a nulliparous patient. But this, certain societies use 2 hours and 3 hours as the cutoff, provided the fetal monitoring shows there is no fetal distress, there is no maternal distress, and no other factor which is obstructing or can potentially obstruct vaginal birth. Now, deep transverse arrest, as I said, lateral positions of the occiput are common, but most of them will rotate anteriorly. But if it remains posterior, in Oxford posterior position. It can rotate 45 degrees and become Oxford directly posterior, or remain in Oxford posterior position. This deflexed head where it's occipitofrontal diameter presenting, or with inefficient uterine action. Another thing is pain relief in labor or epidural analgesia is also associated with a higher tendency of prolonged labor and sometimes Oxford posterior. So these are various factors, and again, chance. You can't predict why in a particular woman she has landed up with Oxford posterior, but a flat sacrum, anthropoid pelvis, and other things are more common. It is a common position, but it often changes to Oxford anterior. And majority, the good news is, provided other factors are available, majority will deliver by a long arc rotation of 135 degrees to anterior. I will show you that later. Some cases, if the head